We are so, so thrilled to have Dr. Lisa Saldana here, who is really just a national expert in so many areas in implementation science. And we're just honored to have her share some of her knowledge specifically on issues of costing implementation processes to facilitate sustainment. So Lisa is a senior scientist at Oregon Social Learning Center. And a lot of her work has been on evidence-based practice in public serving systems. She's a clinical psychologist by training, an implementation scientist, and an intervention developer. And she has been focused on this for, again, many decades, the work that she's been doing. She developed FAIR, an integrative treatment for parental opioid and meth abuse and child neglect. She created the R3 supervisor implementation strategy, and has done a lot of work to kind of support the culture and climate of frontline caseworkers. And she also developed many tools that many of us have used in our own work, the stages of implementation completion, and the cost of implementing new strategies, the COINS measures. So we are just so honored to have her here, and I will hand it over. Thanks.
Thanks, Rachel. Good morning, everybody. Nice to see some names that I recognize and some faces that I recognize as well. Good morning, folks. Yeah, thanks for the intro. All of those things that Rachel sort of described, I'll touch on a few of them today as we do talk about costing, but really today I'm going to be focusing on that last one that she mentioned, the cost of implementing new strategies, the COINS approach, and how we can start thinking about costs when we're also thinking about implementation. So again, I'll be talking about costing, and in particular, when we think about implementation, especially now that we've sort of codified all these different elements of implementation, I want to make sure that we are all on the same page, that today we're talking about implementation process as opposed to costing like individual determinants or facilitators that we might be aware of. Okay, so first I just want to acknowledge my COINS team. I really should be acknowledging the full SIC team because, as you'll see, COINS really builds from SIC, but these are the individuals who have an economic focus and who really help us as we are managing this cost data. Okay, but to start off with, I do want to have a disclaimer. I myself am not an economist. I'm not trying to be an economist. And so there was a lot about economic evaluation, a lot about how we think about economic analyses that is just pretty much outside of my wheelhouse. However, what I am is I'm an implementation scientist who cares a lot about process and cares a lot about how it is that we can ensure that we can deliver evidence-based practice in an equitable way. And not surprisingly, financing and economics comes into that and comes into play quite a bit when we are talking about what is and is not going to be feasible and viable for all of our community members, and not just paying attention to the things that might be useful to those who are really well resourced. So when we also think about sort of, this is the CFR model, I'm sure you guys are all familiar with this, one of the older images, but when we think about economic analysis, it gets mentioned quite a bit in the implementation science literature, but really where it sits typically is in the intervention space. So what are the costs associated with the individual strategies that it takes to implement an intervention, such as maybe coaching or training? So individual activities for a particular point in time in implementation, versus what we're talking about today is really the full process. And so the entire time from when you're even thinking about adopting evidence-based practice or non-evidence-based practice, any sort of practice, all the way towards being able to reach sustainment. And when I think about equity and think about implementation process, we can really look to some of the other leaders in our field. And so back in 2015, Per Nilsson, I'm sure you guys are all familiar with this work, really helped to define what we think of when we think of implementation process. But then Anna Bauman and Leah Cabasso, they more recently have talked about how we can think about implementation process when we're thinking about health equity. So together, together, what this literature helps us to support and build a foundation for is that really when we're thinking about equity, we want to think about describing our process from the start. We want to think about what is the sort of the sequencing, the time it's going to take, the steps that it's going to take, and how can we make each of those phases and stages that are part of process models, how can we make those achievable and accessible to all different types of communities? Part of that, of course, is how we design and select our interventions, but a lot of it also is how we can figure out not just the intervention that works, but how can we make that work in a cost-effective and resource, as much as resource limited as possible way, where we're still achieving those good positive clinical outcomes for the vulnerable population that we have in mind. So our work that I do, oftentimes process models that we're used to often map onto EPIS, or the Exploration, Preparation, Implementation, and Sustainment Framework by Greg Ahrens and colleagues. We really like this because it does map onto the way we think about and the way we measure implementation process. So the stages of implementation completion, or the SIC, as I will refer to it throughout this presentation, is an 8-staged model that we developed to measure this full range of implementation process. And so here you can see that we have our pre-implementation phase, which includes engagement, feasibility, and readiness planning. And those sort of situate within, we've done some mapping exercises within the exploration and preparation phase of EPIS. And then we have our active implementation stage, which maps onto, for us, where you're hiring and training your staff, where you are setting up any of your fidelity monitoring systems, where you're actually launching the program, starting to serve patients, whatever that means to you. It might be screening, it might be actually treating, it might be identifying different patients. And then Stage 7 is our ongoing services, fidelity monitoring, and that's sort of like where you're just doing your thing. You're just getting it going, and we're getting it off the ground now that it's been launched, as you are developing strategies towards developing competency and delivering that program, with the idea being that once you're competent, you then are able to think about sustainment. So this is something that I think a lot of you have heard me talk about before, these 8 stages that map onto these phases of implementation. The key is that we are talking about the entire implementation process and not limiting ourselves to just this active implementation part of the process, this gold part. So the stages of implementation completion, as I just pointed out, has these different phases: pre-implementation, implementation, and then sustainment. Within each of these different stages, there are different, these are just examples, there are different activities that we would expect that different agencies, communities, individuals, whoever the implementers are, that they need to achieve different sort of milestones, if you will, in order to move through the process. And so these are examples. On the SIC, what you will see is that all of our examples are date driven. And part of that is because time is an really important critical factor when we are trying to predict implementation success. And relatedly is really important when we're talking about dollars and the amount of resources that we are spending. So again, these are just examples. When we create and operationalize the SIC for different projects, the number of examples underneath each of these stages is highly variable. However, we do know that we have about 46 items that are common across all of the different implementations that we're working with. We refer to those as our universal items. And so you can imagine that at the very minimum, there are going to be 46 sort of implementation activities that somebody would be expected to go through in order to achieve a sustainable program. However, we want to think about the fact that when we're measuring this, it's not linear the way that it looks on our nice little stair-stepped figure. In fact, we know that it's really recursive. There are lots of different people involved. Sometimes, like we might be doing really well, and then we have to take 5 steps back. We experience turnover. So all of these, the non-linearity of implementation process is not only challenging to measure, but when we're thinking about resource use and thinking about capturing costs, we're really interested in making sure that we don't lose those costs when we take our steps back, because that is oftentimes incredibly important in terms of the resource use, in terms of what an agency may or may not have expected or budgeted. So if we can get on top of what the expectations are in terms of the twists and turns and the nonlinearity and sort of the resources that map onto that nonlinearity, we can use that to in advance inform some of our community partners who might be interested in adopting these evidence-based practices, because then they're not so blindsided. So when we think about the SIC provides a roadmap, again, that allows nonlinearity. It's got twists and turns in it, but with the idea being that as we go along these twists and turns, we're always sort of hoping to achieve the sustainable use of what it is that we are implementing. So these are each of the different implementation stages. And you can imagine, again, the amount of resources that go into completing each of these stages. You can also imagine that right here, these pre-implementation stages at the beginning of implementation, they are more recursive, and we need to go back and we need to do sort of revisit readiness planning, and we need to revisit feasibility assessments. And so the costs associated with pre-implementation are incredibly important, particularly so because we know that in order to sustain practice in the real world, that the most important phase that we need to really build our infrastructure in is that pre-implementation phase. So the summary of our SIC outcomes, we've used the SIC, I think some of you know, over 2,000, tracking over 2,000 implementations worldwide. And sort of regardless of what it is that we're implementing or where we're implementing, doesn't matter the service setting, doesn't matter the country, what we end up finding, you guys have probably seen this slide before, because it's really consistent that pre-implementation predicts successful program startup. It predicts whether or not a program is going to discontinue in the future. And then the interaction between pre-implementation and implementation behavior combined really helps predict whether or not a site is going to achieve competency. We have not showing the data on pre-implementation sustainment today because that's not the focus of the SIC. However, we do have data that really describes that in the absence of a quality pre-implementation process, no matter how wonderful your active implementation phase or stage is, we still won't make it to sustainment. So again, pre-implementation is key for sustainment, and understanding the resources that it takes in order to engage in this nonlinear pre-implementation phase is essential. Because we all know that implementation has costs. It has costs in the form of money, it has costs in the form of direct dollars, and it sometimes has costs in the form of these indirect dollars, or dollars that are not quite as obvious to us when we're thinking about putting together our budgets. So why is this important? Well, the importance of cost and implementation, I think, is probably obvious to everybody on this call, or else you wouldn't be attending this particular meeting. But really, when communities or decision makers are weighing whether or not they are going to adopt a practice, they are considering the full range of costs. Oftentimes, what we've heard from folks when we've done our work in the past is that sometimes decision makers feel blindsided. They feel like the costs that are sort of made known to them at the front end when they are making their decisions are those that are limited to the intervention costs. And oftentimes those intervention costs also kind of take into account our side, the developer side, the researcher side. How much do they need to pay us in order to achieve or receive our facilitation or our coaching or our consultation? So we've got fixed costs that are part of the process for them to implement these interventions. However, from their end, the ones that are actually forking out the money, there are a whole other range of implementation costs that get ignored. And so we need to consider, what are these implementation steps that we're asking folks to go through? Are they really necessary? And what are the resources that we need to consider as we are asking them to take those on? So there are some obvious value to standardizing costing strategies. One is that for these decision makers and policymakers, for them to be able to make comparisons across different programs so that they're better informed about how costs can vary over time. One thing that I think is incredibly important when we think about implementation process is that when decision makers are looking at a budget, they might originally think there is no way that I'm going to be able to afford this particular innovation that I want to bring into my healthcare setting or my hospital setting. But if looking at the process, we can show how costs are sort of phased in the implementation process. It might then be that they can revisit that idea because we can help by making these costs transparent. We can help them really figure out the timing and the budgeting for bringing in these programs into their setting. And now, lo and behold, there might be some opportunities to be able to do some finagling with the budgeting and with the timing to make that feasible. Obviously, it's also important to us as researchers and developers and our purveyors who are offering technical assistance. For us, we want to know how expensive it is. We want to be able to do our economic evaluations. A lot of times, right, we have that aim 3 that we want to be able to figure out even in our implementation projects. And then obviously it helps us in terms of understanding we want to decrease our implementation costs so that we have more customers, more folks who are interested in adopting our programs. But the question then becomes, whose costs are we talking about? And again, oftentimes what we see in the literature is we see the cost for a particular strategy in the active implementation phase, or we see costs that are related to a particular individual, to the purveyor, to a provider. And so what I like for us to encourage is that if we are thinking about large scale up, we're thinking about bringing these innovations to our most vulnerable populations in communities that are under-resourced, then one of the things that we really want to think about is what are the costs to those communities? What are the costs to those implementers? Those are the sorts of costs that decision makers are most worried about. The decision makers are less worried about how many hours or what the cost is for me as a coach to be able to deliver that coaching strategy to a particular individual. It's only important to them so much as that then becomes a fixed cost as they are trying to determine whether or not they can afford a program. So when we think about these decision makers, which is the lens that I'm going to be talking about as we go through the rest of today, I want to think about there are some emerging costing methods, assessment methods that are coming out in the literature. And really what the commonality is between these is that what we're finding is that there's an obvious need to disentangle these intervention and implementation costs from one another. They come from different buckets, often in agencies of money to be able to afford. It absolutely plays into being able to write and respond to RFPs that different agencies are responding to. But then again, for us as researchers and as those of us who are trying to understand how we can make greater efficiencies, we really want to be able to understand, are we cutting into the intervention or are we cutting into the implementation? Obviously, we build on traditional cost effectiveness analyses, but oftentimes what is different is that we are now looking at implementation outcomes as opposed to those clinical effectiveness outcomes. So our denominator and what it is that we're paying attention to is, are we achieving reach? Are we reaching the population, penetrating, the different systems that we're looking at, and looking at, are there differences between implementation strategies? Maybe both will achieve the same outcome, but one requires more cost than the others. And then also to help us define the implementation process. So just a couple of examples from the more recent literature of others who are doing this work. This was a really nice paper that was out. One of the things I loved about this paper here by Son and colleagues is that they're really looking at the difference in costs at the site-specific costs, but then also research costs and the programmatic costs. So like I'm talking about, looking at the different perspectives and how those costs vary and change over the different implementation processes, so over time in the phases. Here's another one by Sidav and al. I don't think I pronounced that correctly, but regardless, apologies to the author. But this was a really beautiful piece because what it did is it made it visually, very visually accessible to be able to see how different implementation costs vary again over these implementation phases that we're talking about: pre-implementation, implementation, and sustainment. And we see that who the actor is, who is involved in the implementation process, makes a really big difference in terms of these costs. But then that brings us to my work and the work of me and my team. So the cost of implementing new strategies, or COINS approach. I know folks have heard about this for a while. It's been on the scene for quite a bit, but it's really started to pick up in terms of its use more in recent years, as folks have started to become interested in, again, this sort of cost of implementation process. So the COINS process maps directly onto the SICK, which is why we went through the SICK explanation earlier. So across all those different activities that we would operationalize that fall under each of those 8 stages, again, that are in the 3 phases, there are direct and indirect costs that are associated with completing each of those activities. Some of it is staff salaries. Some of it is from actual receipts, like maybe there's travel costs, maybe there are purchases of things like Wi-Fi equipment, audio recording equipment, things like that. But then there's also hours that are required. I will oftentimes get asked about this particular thing where I talk about hours in human resources, because a lot of folks will say, oh, well, why, how is that any different from the staff salaries? And in fact, particularly when we're talking about going into under-resourced or low-resourced areas, a lot of times the activities that are completed are done from good community will, from volunteerism, from folks who are coming in and really giving of their time and giving of their hours in order to complete those tasks. That does not mean that there's not a cost to that. It might not be that direct dollars are being spent, but we would want to make sure that we capture that, so that as we are providing guidance or recommendations to a new community, that they are prepared for those sorts of costs and recognize that there might be an opportunity to pay for some things, whereas in other situations, you might be paying for it forward with some volunteer hours. So common pre-implementation costs. So in that first phase, these, again, this is not rocket science, and some of you have probably seen this discussed by me before, but this is where we have a lot of costs related to engaging our community partners, identifying who's going to be part of our team, sort of establishing the feasibility of the program. And so there are lots of things that are kind of the nuts and bolts, right? Like getting your contracting in place, being able to assess what your referral flow is going to look like, determining who your referrers are, those sorts of things that go in those first few phases in the pre-implementation, stages in the pre-implementation phase. All of those are things that oftentimes are ignored, but have very, very real costs to them. And as you heard me describe earlier, are essential to complete in order for us to have a sustainable program in the future. However, a lot of times people think of these as sunk costs. These are costs that that don't ever get captured and sort of are ignored by those of us who are not behind the scenes at a particular agency or hospital in being able to conduct these, whatever it is that they're adopting. Then we have our active implementation costs, and these are the costs that we think about more often, right? These are our staff hiring, the trainings that folks need to go to, any of the fidelity monitoring systems they need to get in place, the travel costs associated with attending those trainings or clinical needs. These are the sorts of more traditional costs that we think about when we're thinking about implementing a new program. And then finally, our sustainment costs. These are kind of these recursive costs that happen. A lot of times we have to go back. My team and I recently have been doing a lot on defining the sustainment phase. So after those 8 stages of implementation. And what we are finding is that a lot of the activities are really having us go back to readiness, having us go back to feasibility assessment. And so reenacting some of those activities now that we are on the tail end and we're trying to sustain, we're going to have some of those repeated costs. And those costs might look a little bit different now that we are sustaining a program versus trying to start a program. So how do we collect all of this information? So collecting COINS data, here I am, the little implementation scientist wanting to operationalize process and figure out how much it costs to do so. So this is a web-based system that we have. The SICK overall itself is a web-based system. It's a web-based tool. I just want to note, because people ask me this all the time, the items on the SICK and the SICK as a framework is in the public space. But in order to, sort of access the tools online and have us customize and adopt programs for you, that's something that that we do through contract. So online, what we would do, this is an example of what the data entry page looks like for, and this is, I pulled up one of the examples from a Columbia partner there who I know is on the phone, Milton. And so one of the things that's really important to notice is that we are tracking the date in which different activities happen. Right? We can translate so that we can go across different countries. But one of the things that we are looking for is that, so the SICK part of it is tracking the date, but for the COINS part, what we do is we COINS enable we COINS enable different activities in this process that we think are going to be really important for us to be able to determine what the resources are. The reason why I say that is collecting cost data is a different level of burden than collecting SICK data. So when you're collecting the SICK data, we just want to know the date in which each of these activities were completed. But to go back and get the receipts, to get the number of hours, who was present to complete those activities for the COINS data is obviously more. So what we encourage folks to do is to look for what are the activities where we think there's going to be variation between different strategies that we might be comparing, or where we think that there's going to be a lot of hidden costs, and we try to operationalize those. So we're not operationalizing every single item that we've defined on SICK, but we're looking at those that we think that where the resources and the costs are going to be most important for us to make our decisions. One of the ways that we do this then is that this is again the data entry page. What I was showing you back here is the staff hours, but this is where we do it. So when we, if you are in the SICK website and you are here in stage 3, you're doing your readiness planning, you could be, it's a calendar entry, data entry, but what you would do is you could press on this button here if you want to update your team FTE and the direct costs related to these stage 3 implementation activities. So there are staff hours that are tracked at the individual activity level, but then the direct costs and the team FTE is calculated at the stage level. So it's aggregated at the stage level. We collect things. We have pop-up menus that come up on as you're doing your data entry that will guide you towards completing the direct costs associated with completing an activity, as well as updating team members and team member FTE. So when we experience turnover or when we are bringing on new individuals to our implementation team, we want to be able to capture that so that all of those FTEs are not missed. Then what we do, and here it is with the effort, tracking the amount of effort. Then what we do is we take these costs, particularly those related to FTE, and on the back end, we map them onto the Bureau of Labor Statistics so that we are able to get the FTEs so that it can be generalized and standardized across different environments. Obviously, when we're working with other countries, we need to map onto whatever their labor statistics sort of public database is so that we can make those costs generalizable. And then within the sick website system, this is just an example. This is not real data. And so you see there are a lot of zeros here because it was just put together quickly as a demo. But then within the sick system, we have a whole bunch of reporting features. And so the behind the scenes, the coin system will calculate for us, for instance, here, the average number of hours by stage per position. And this again will allow us then, as we are collecting our cost estimates for our future economic evaluation, to be able to slice it however we want to slice it. Do we want to do it by phases? Do we want to do it by particular stages? Are we interested in perhaps how costly the readiness stage is using one approach versus the readiness stage using another approach? So the coins reporting features allow us to break it down into these different increments. Here's an example of, this is in a paper that came out last year, but here's an example of how the coins tool allows us within the online website to be able to look at the variation in cost in hours versus cost in dollars, because again, whose hours matter. And so it might be, this is an example here, we have two different conditions. One implementation strategy is the individual implementation strategy. The other is a community development team implementation strategy. The costs of these particular activities that are defined for this analysis that we were conducting, we see that the costs are less for the individual condition than it is for the community development condition. But we see the number of hours is really quite different between each of the different conditions as well. And so knowing again the hours versus the costs can really, really make a difference behind the scenes as we are trying to decide which approach are we going to do if we assume that both approaches get us to success. So the coins process applies across, again, the cost mapping across all the different procedures to evaluate the resources from the full implementation process. And then when we combine this coins information with sick data and our other implementation outcomes that we are looking at, then we can answer some of those more traditional economic questions that are important to decision makers. So for an example, and this is the example, I'm going to go through the examples that are provided in this manuscript that was just released last year. And then I'm going to provide a more recent example from a current trial that we are conducting. But right here, this basically what I'm going to be showing is that we can take all of those costs that we were talking about using the coins approach. If I go back here real quick, these from the example that I'm going to show you first, these are different activities. These are the activities that are on their sick that we have operationalized. So you see, for instance, this pre-implementation phase, we have a lot of activities in stage 3, et cetera. So this is what we're costing. And when we do this, one of the things that would be important to, again, a decision maker would be, what is the risk that I am taking when I am investing dollars into this pre-implementation phase, knowing what we do know, the reality, the unfortunate reality is that a lot of sites that attempt to implement something never make it to launching that program. So using what we know from the sick, which allows us to look at discontinuance and allows us to look at predicting implementation success, and combining that with information that we gather from coins, which helps us to cost each of these different phases. If we are looking at the site level, so what is important to a decision maker at a particular site, what we can see here is that over the different stages, we have different percentage and risk of discontinuing. So the risk for each of these two conditions is the same, that they're going to discontinue prior to stage 2. But what we see is that the total cost of failure prior to stage 3 is quite different between the two conditions, and the percentage of the population failing prior to stage 3 is quite different. So if you look here and we were to stop our analysis at this point in time, we would say, well, holy smokes, of course the CDT is the most obvious condition to go for. Fewer people are going to fail prior to that point, and there have been fewer dollars spent. However, if we advance to the next stage of implementation, what we see is that, oh, well, gosh, a lot more folks then are now dropping out at prior to stage 4 for that CDT condition. And so the costs have gone up dramatically and more people have dropped out. For this other condition, the costs have remained the same at stage 3 and no further sites have dropped out. And so ultimately, we end up at the end with a very similar proportion and rate between these two different implementation approaches. But what we see is that there's quite a bit of difference still in the amount of cost that it takes for us to get there. So a decision maker could be thinking about that along the way. Where do they think they're going to put their efforts in what phase, and where are they going to be particularly careful about not being able or not dropping off? So again, the numbers of hours also significantly varies between the stages. So this is that chart that I showed you before. And again, although the dollars, we can very easily look at dollars, there might be a situation where an agency says, oh my gosh, CDT is obviously the route that we want to be able to go. It's going to be most likely that we are going to continue on. However, we can't afford it. It's too expensive. Knowing that, okay, we're going to put in a lot more hours probably if we do this individual implementation route and use this approach, we'll put in more hours, but we still have the same likelihood of achieving success. This now allows us to think outside the box and think, oh, wow, maybe we can implement this. Before we thought it was unachievable for us, but perhaps we can. So now again, if we look at this total cost of failure here in stage 4 and pull that forward into a different analysis, where now we're looking at what are the sunk costs by condition. So now we're focused by condition. Now we might be researchers or purveyors rather than individual sites that are interested. And what we see here, this is doing a basic economic analysis where we take our failed sites costs related to our successful sites costs. And then of course, the number of sites that actually end up placing, in this case, youth, are starting their program. So we're just doing our basic sort of cost effectiveness analysis. And what we see here is that, okay, lo and behold, the CDT costs less, but that is also because they are able to, more sites are successful. And again, but we look at in terms of the sunk costs are actually less for the IND. So these are all different things. These look like big differences, but in the grand scheme of things, and when we're talking about budgeting and looking at programs to sustain into the future, these costs really are not that different from one another. And these are, again, are the sorts of things that if we make transparent, then our decision makers are able to make informed decisions. And then lastly, here's an example if we are doing the average youth or the average patient cost by condition. Again, we're using these same sort of dollars that have come into looking at, again, the implementation process. But now we also have to combine not just the process, but what are the costs related to this particular patient. So specific patient costs, looking at those averages. But again, we look for the CDT condition. They place a lot more youth per condition. And so the average cost per youth ends up being less. So that all seems, again, pretty straightforward. However, when we're thinking about, oh, I'm sorry, I forgot about this. So if we're doing just a typical cost effectiveness analysis, then of course we're going to be doing our t-tests. We're going to be looking at the comparison between them. And we see that the IND condition ends up actually costing quite a bit more per youth. And they actually place less youth. So again, at this point, one might suggest that you would go for the CDT condition by site. And then finally, you can use the exact same estimates that come out of COINS, the COINS process, to be able to look and see how long is it going to take for us to be able to recoup all these pre-implementation costs that nobody else was paying attention to except for me, the site or hospital administrator, decision maker. Well, one way that we can do that is we can look and see here, okay, the total number of youth placed, again, for this particular example, it looks like at around 11 youth is when a particular program would start to recoup their costs again. So this is where we can look at traditional economic analyses that we do. This is using youth reimbursement or patient reimbursement to be able to see how long it takes for us to, again, recoup those costs that went into starting the program to begin with. Another shorter example that I have here is for a more recent trial that's ongoing right now. And this is an example of how we as researchers might be looking at economic information as we're building a program. So FAIR, their Families Actively Improving Relationships program, is a program that my team and I developed specifically for parents involved in the child welfare system where there are complications of opioid or methamphetamine use disorder. This is a program that we are now studying the scale up of in different rural communities. And so here's an example of two different clinics that have really different contexts. The first clinic is on the coast, and it is an already established clinic. They've got all of their licensure. They're running a whole bunch of substance use treatment programs already. They have significant experience, and they have the infrastructure and all the staffing in place. Versus our second clinic, which is more inland, and they are established. They had to establish the clinic. There was no clinic that existed in the area, and there was no FAIR or SUDS specific services for families in the area. So two really different contexts, one existing clinic, one newly building clinic. Both of these clinics are bringing in this exact same new evidence-based practice into their structure. We operationalized the SIC just like we do with all of our programs. And so this is just an example of the roadmap that we came up with of all the different SIC items. But really what we find using the COINS process, again, is that between the two different conditions, perhaps not surprisingly, the less experienced clinic where they are really building the infrastructure, getting rent, finding a building, turning the electricity on, buying equipment, that clinic ended up spending significantly more money than the well-established clinic. But what we see here is that it's actually very similar. Again, this is somewhat more controlled than what we would see in the real world because it is a trial. And so we are directing and guiding a lot of what they do in their implementation process. But in so doing, what we see is that there's not a lot of difference between the groups in terms of things like signing agreements and the expert consultation they're receiving from us. It really comes from the amount of hours that are being spent in this pre-implementation process. And here it is broken down. We can see again that Clinic 2, the clinic that's building, they had some hours or some staff costs that weren't even represented in Clinic 1 at all. And when it was represented, it's much less in Clinic 1 than it is in Clinic 2. Okay, so again, here we're thinking, okay, Clinic 1, absolutely, right? They were able to pull this off at a much less costly, implementation process approach. However, what we see is at this point in the trial is not over. We still have several years to go. But at this point in the trial where they're starting it at the same time, that first clinic is seeing significantly fewer patients than the inland clinic. This is not due to, population size or anything like that. It is due to the infrastructure and what is in place at each of these two clinics. However, if we were to do our cost effectiveness analysis, what we would see is that the cost is still less per patient served for the coastal region. However, we are implementation scientists, and is it that we are most interested in, again, assuming that the trial ended today, which it's not going to, but would we be most interested in the amount of dollars served or needed to serve each patient? Or are we most interested, what we're balancing are reaching more patients, serving more patients? And if we are able to do that at an affordable cost, knowing, again, this is important, knowing that when we are starting our program and the number of patients served is going to help us predict into our future sustainment, the chances are greater that this amount of dollars is going to go down dramatically over time as we continue to serve more and more patients in a more solid infrastructure than in this particular site where the referrals are coming in much more slowly. And to be quite honest, they spent less dollars on building their infrastructure, but that also means that the infrastructure that is in place to support other programs that are not evidence-based, and they're quite different from the type of work that this particular model, the FAIR model, is asking folks to do. So in actuality, it turns out then that from my standpoint, that this inland model, although again, the cost might not suggest that, from what's important to me, this would be the superior at this point in time site. So in conclusion, implementation costs are very real. They often get ignored, but they're real, and they can have a significant impact on our overall success. They can make a significant difference to the different decision makers. Our implementation costs are incredibly necessary, and if we ignore them, they really, really can lead to mistrust by our decision makers, feeling like we are not providing the full range of costs and the full expectations for them up front. And it can lead to failed implementation by, quite honestly, not estimating enough in terms of the costs that are needed to sustain a program. The implementation activities or SIC activities are most valuable for yielding successful implementation are the ones that are the activities that are worthy of investment. So again, if I think back to those 46 items that we know are necessary to be able to sustain implementation, those are the items I would look to first. I would not want to do cost-cutting measures and get rid of those, but instead I would want to understand what are the costs in the particular context to complete those activities, and are there ways that we might be able to streamline how they complete those activities to reduce the cost, but I wouldn't remove those activities. And then finally, our methods for analyzing costs are really similar to those in our traditional effectiveness methods, but again, we're targeting now our implementation outcomes. So the way that we interpret the outcomes that we get might be quite different because what we're interested in is different from our traditional clinical effectiveness trials. So thank you very much. I appreciate you guys listening.
Thank you so much. That is just such a tremendous wealth of resources and tools that are so relevant for both research and practice. So thanks for sharing all of that.